Good morning, everyone. And thank you very much for the invitation. I have to say that it has been really fun to make this presentation with Jennifer for the last couple of weeks. And it has also been really fun to hear everything that you guys are doing during the last 2 days. I have really enjoyed the lecture so far. So putting this presentation together was a little bit of a challenge because there's a lot that we can discuss about implementation and the implementation. So we just want to kind of like highlight that this is not exhaustive of everything that is out there about these topics. And then second, that a lot of this is going to sound very, very technical. So I think one of the things to discuss is how we can make some of this wording sound more of like a care that fits or care that is careful and kind, because it doesn't have much of that. Is, if anything, very kind of like practical and technical to a certain extent. So what we'll do today is that first I'm going to start with an overview of both implementation and the implementation, and we'll have a break there to talk about how could this sound more, as I said, as a care that fits. And then Jennifer will discuss in more detail implementation science and provide an example, and we'll break out in rooms to kind of like work toward an example of something we want to implement. And then we'll come back and then I'll give you more information about the implementation, and we'll work on an example of something we want to de-implement. So with that background, many of you might have heard this number that it takes 17 years for research evidence to reach clinical practice. And I think most of us will agree that that's like a long time and probably not good. And if you think of that pathway, you can start with kind of like the basic science discovery, that then is taken to control and efficacy trials, eventually to pragmatic effectiveness trials, real world data. And then we're really sure that we want people to be doing this. So we want this to be part of daily practice. Obviously, this is not like a complete linear pathway. Sometimes you can have observations in the clinic that then lead to basic science discovery that end up helping people with completely different set of circumstances. But the idea of implementation science is really to understand this process, so that then what you understand, what are the factors that are helping or making things harder or more difficult to translate into practice, so that you can develop interventions that you can facilitate this process and make it take less than 17 years. On the other side, then we have things that we are doing in practice every day. And when you look back, they might have no evidence, or they might be actually evidence that they are harmful for patients. So here, what you want to try to do is understand that process of how you take something out of practice and then facilitate that process of the implementation. So kind of like the opposite. Now, this is important, and I think kind of like we are discussing it in the Care That Fits conference, because if our overall goal is to kind of improve the health of patients, we're living in a translational paradox. So on one side of the equation, we have that there's limited use of effective evidence-based practices. And we could define this as saying those that if patients are presented and engaged in a conversation of risk, benefits, and the situation and so on, most of them will agree that these practices are probably things that they want to do because they are going to be beneficial. And then on the other side, we have that there's excessive use of ineffective practices. Again, we were to discuss with patients. Most of them will agree that this is providing no benefit for them, so they wouldn't want it. So at the end, this is leading to harm for patients, and then also to waste of resources, both from like a societal perspective, but also for patients. So what we're trying to do, or the whole background here for implementation science, is to work on this side, where we're going to increase the uptake of the things that are effective. And then on the other side, we are going to de-implement those things that are not beneficial or harmful or wasteful. And as I was kind of like going through these slides yesterday, I must have made this slide on a day that I was feeling particularly optimistic, because I completely like just make this tilt the scale completely, so that implementation science is gonna lead to this massive increase of uptake of evidence-based practices and completely decrease the use of ineffective practices, which is probably not possible. And the final outcome then will be, as I said, improve population health. This is an official definition of implementation science, and I'm putting it here because I think it's more formal than the explanation that I tried to give, but also to kind of like, again, highlight how some of this wording doesn't sound very like patient-centered. and the other to just showcase some words. So this implementation of science is really studies of methods to promote the adoption of these practices, and then it's really looking to improve population health. And this is a relatively new science as a science itself. Like if you look at PubMed, these are on the y-axis, sorry, on the x-axis through the years, and then on the y, the number of articles that include implementation science. You can see that it has really increased in the last few decades. It's not that these problems are new, they are probably have been there for a while, but it's now that they are getting kind of like formal attention and being, this process of understanding the methods is being labeled as a science. On the other hand, I'm sharing these two definitions of the implementation. The first one, just to highlight that all this understanding that process will have two steps. One step is just kind of like identifying and prioritizing either evidence-based practices that should be implemented or de-implemented. And then the second, that during the years, there have been many different words that have been used to define this process. So here you can see like discontinuing or abandoning, and there are some other modes. And that can explain, like, if you look at the same graph, like, so again, here are the years, and then how many articles have the implementation science on their title. This is kind of like newer. So it seems that paying attention of things that we shouldn't be doing has gained more enthusiasm more recently. But in the past, there some of the articles might not necessarily use the implementation. They might have just say abandonment or disinvestment or many other words. So this is kind of like the summary, or kind of why this is important and why I think this fits to the work that we're trying to do, although some of the wording, as I mentioned, is not the best. But we're just trying to increase the uptake of things that we really believe are going to help patients, and then limit the use of those things that we think are harmful or providing no benefit to them. So with that introduction here, we had first kind of like an activity of just hearing people's experience of work, trying to fix this translational paradox, or more formally, working in implementation or de-implementation science. But an additional thing that we can discuss at this first break, obviously, if you had any questions of what I have said so far. But again, if you think the wording is too far off from a Care That Fits conference, I would be really interested on hearing those, because I think the goals are good. It makes sense, but maybe it hasn't necessarily been written in a way that will resonate with most people in the room or online.
I wonder if you could talk about how this fits into the realm of online education through YouTube. There are different physicians and other groups getting out there and trying to put themselves into places where they're educating the public broadly about specific science and how to use science and medicine to improve, whether it's self-management through weightlifting or running or whatever the case may be. Are these technologies, are these new forms of communicating to patients, in your estimation, a way to overcome some of this implementation challenge? Of getting data, translational challenge rather, of getting data to patients more effectively?
I can start, and Jennifer, you can add on to that. So I would think that with this, with implementation or de-implementation science, the emphasis is not so much on kind of like creating that evidence, or as they were discussing before, figuring out if something is helpful or not. It's kind of like once you have identified that something is helpful, and once you have identified that or that is not helpful, then how you actually integrate that into practice. So in the question that you asked, even before or as you're thinking of those ways of getting the information out to the public or to students or whichever the group would be, very, very conceptually for implementation and de-implementation science, you must have first kind of like proven that this is something that is going to be beneficial or helpful for people. And then it will come to this very kind of like late stage translational kind of like science, where you're trying to see how we can, how we can increase the uptake of these things that help. So if you show that educating people online modifies whatever outcome you're interested in, then you say, okay, how we can have more people educating others online. So that's kind of would be the way of using this way of thinking to fix the problem that you're alluding. Jennifer, I don't know if you had any other thoughts on that.
No, we'll talk a little bit about the difference between intervention and implementation research when we get into that next section. I see Zoe has her hand up as well.
Yeah, I'm sorry, I was trying to be quiet. Yeah, that's really interesting. I think in the UK, we talk about knowledge mobilization. I think there's lots of different terms for it, and maybe it's called knowledge translation a little bit more in North America. But the knowledge mobilization kind of overlaps, I would say, with implementation science. And maybe there doesn't necessarily have to be an evidence-based thing that we are trying to implement. It's about this kind of two-way sharing of knowledge in efforts to improve practice, which may involve evidence-based interventions, but can also involve practice-based learning, patient experience, and all sorts of things. So I see that where it's really, I hadn't thought about it before until you said it, which is really interesting, that the language of implementation science doesn't really sit very nicely with care that fits in a patient-centered perspective. But I think the language of knowledge mobilization does and can, because it's a lot broader, and the knowledge, the thing that you are sharing it can be conceptualized as much bigger than evidence-based medicine. So for me, I would, and Stuart's comment about YouTube videos, I think knowledge mobilization is about understanding your community, your context, and then using different channels to communicate. And so to me, that would be part of the kind of knowledge mobilization revolution, if you want to call it that.
Yeah, and I think that brings out the other point of kind of like there's that boundary between the quality improvement and the implementation science that is to a certain extent a little bit artificial. So some of the work that you're alluding to, probably if you have kind of like a broader definition of implementation science, you can include it there as well. But yeah, that's there. I think in Canada, they also use different terms, and that's what I was trying to showcase, that more recently, they are, at least within the American context, implementation and the implementation have gained more, kind of like people are supporting them more. But if you look, people have been talking about these topics from way before. So yeah, Jennifer, I think if you want to move to the next part, that would be good. Or I don't know if there were other questions.
I see a comment in the chat from Michael. I think more of a comment than a question, but a very good one. No other questions? Should we move on? Do you want to continue through the slides, Naykky, or do you want me to grab control?
I have a comment.
Okay, Victor.
So there's a direction, when you talk about evidence mobilization or knowledge mobilization or knowledge translation or evidence translation into practice, or the overcoming of gaps in translation, that there's a direction of the arrow that goes from the evidence production into practice. And so the tension that Naykky was mentioning at the beginning, it may come from the fact that here we're thinking about how do we help this person? And there, the job, it looks at that arrow right at the tip of that arrow. In other words, we're looking in the other direction, in that we're interested in drawing from the best available research evidence, patient experience, all sorts of different knowledge sources and evidence sources to try to work with this patient to find ways of helping this person. So there, it's not that, oh, we have all this evidence that we keep producing and funding to produce, but nobody's using, we have a problem. And so now we have an evidence to translation, to practice translation problem that we have to fix, that captures the imagination of policymakers who are spending money on producing evidence, of funders of research that find that it's futile to fund this research, nobody's going to use it, and so forth. But the problem we're trying to solve here is not the problem of funders of research or of policymakers. The problem that we're trying to solve here is the problem of care. How do we take care of this person? So that I think is one of the tensions is we're not interested in the fact that there's a lot of knowledge that doesn't get translated. We're interested in that there's a lot of care that perhaps is not benefiting from using the available knowledge to inform it.
Thank you. I don't mean to cut off the conversation. I'm going to move to the implementation section. so that we can have some breakout time to talk about some of these things in our smaller groups as well. So we've broken this presentation kind of into two sections, implementation and de-implementation. I'll talk about implementation and Naykky will come on and talk about de-implementation. A lot of the constructs will apply across both. We're thinking about the evidence, we're thinking about the setting and the people in which we're implementing the evidence. We're thinking about strategies to increase adoption and use. Do you want to advance, Naykky? Thank you. So I'll go back to this original definition that Naykky gave earlier, which is that implementation science is these methods. It's a science around promoting adoption and use of evidence-based practices, policies, and interventions. And we often think of it as a pipeline. We're doing efficacy research, we're doing effectiveness research, and then we're doing implementation research. And clearly, you can use implementation science and methods from our science in different phases of that. I think probably when we talk about designing later, we'll be thinking about how we're designing interventions that are acceptable and matter to the people that use them. That's kind of an early implementation strategy. But implementation research isn't really intervention research. Intervention research being focused on, is this effective? Implementation research really being focused on the strategies. Now that we know that something is effective, how do we get it to the people that need it? How do we get it to the people who can then use it? Want to go ahead, Naykky? Thank you. So effectiveness outcomes, of course, could be patient outcomes. Did their health improve? Implementation outcomes look different. Let me move this. So these are examples of implementation outcomes. And I'm actually an evaluator by training. So I do tend to think of things kind of linearly and in logic models. So we do something, it has activities, it has effects, it has long-term effects. I often think of implementation outcomes as kind of the intermediary outcomes. So you have an intervention, you would like it to achieve this patient outcome, but in the middle of that pipeline, you need things like implementation outcomes. You need interventions that are acceptable and feasible. Just having an evidence-based intervention isn't enough to affect the patient outcome without the implementation outcomes being realized either. And implementation science is really focused on strategies. So it's around the people and the processes of increasing adoption and use. How do we deploy education might be a strategy. It could be an intervention, but letting people know about the science, letting people know about the evidence would be an education strategy that has an implementation outcome. So implementation questions are different than intervention questions. In implementation science, we're interested in understanding things like what is needed to get this practice into routine use? How do we make this practice sustainable in our setting? How do we take, I'm trying not to read all of your comments as we go, Michael, but thank you. I'll expand the chat again so we can see them. How's that? Thank you. Implementation science is also a social science. And I think probably most of us, many of us have training in social sciences. So we use frameworks, implementation theories, models to understand and describe and predict how things work, how things actually get implemented into practice, how we change practices, how we change behaviors. So we're going to focus on strategies and frameworks that you can use in your example for your breakout. Let's go ahead. So there are different kinds of frameworks and theories, and people in this room have worked on developing implementation theories. There are dozens of implementation theories, models, and frameworks that are aimed at understanding how things are implemented. We're going to talk about determinate frameworks. So determinate frameworks, like a lot of frameworks in the social science, are meant to draw attention to things. And you could think of it as being like a multi-level framework or like a socio-ecological model in the social sciences. We're trying to understand the context in which we're putting this evidence-based practice by thinking about all of the ways are all the things that matter on multiple levels. At its most basic, you could think about just context being different. You're going to take an evidence-based practice, an intervention, a policy, and implement it in Rochester, Minnesota, in an academic medical center. It might look different than implementing it in a rural setting, in a different part of the US, in a different part of the world, serving a different patient population with different constraints on their medical system, for example. But determinate frameworks really draw our attention. So we're thinking about putting this evidence-based practice into a new setting. What are the things that we should pay attention to? Many determinate frameworks exist. The consolidated framework for implementation research is one that is commonly used, but most of them give attention to similar levels, such as this. And again, it looks a little bit like a social ecological model. The personal characteristics, who are the people in the context in which you're deploying this intervention or innovation? How do they feel? What knowledge do they have? What confidence do they have? If you're deploying, for example, a shared decision-making intervention, do they hold knowledge and beliefs around shared decision-making or around the technology that you're deploying? What do they think of the intervention or the innovation? Is it complex? Is it well designed? Was it designed with people in mind that are going to use it? Does it have some advantage over the other things that the clinician or the patient or the health system could be using? Setting is just a general sense of the organization usually. We could think about deploying an evidence-based practice into a community setting, but often the work that we're doing is within a healthcare organization. What is the culture of the organization and how is its work organized? If you're going to introduce a new tool or a new program within the organization, will it be well received by the people who work there? Are they used to doing that type of practice change? Do they have leadership buy-in? Does it disrupt the way that they normally work? What are kind of the organizational factors that you should be attuned to? And then the external environment. I think Carl talked about this a little bit in his presentation yesterday. It could be the policy environment. It could be the area, the type of patients and populations that it serves. It could be positive things, or it could be more punitive types of mandates and things, benchmark reporting, for example, that the clinicians or the other people in that environment are held accountable to. We go in often early in implementation projects to understand where we're deploying the innovation, whether you're part of that setting or you're an outside researcher going into that setting. We should be attuned to context throughout the entire implementation project, but this would be a common thing to think about it when we're going in. We might understand these kind of determinants, these things that might impact how easy or how hard it is to implement this innovation by doing surveys, by talking to people, by spending time in that environment and trying to understand what it's like. Okay. The reason that we identify determinants is again because we want to go back to these implementation strategies. If we're going into an environment or we're in the process of trying to implement something into an environment, we want to know what factors could serve as barriers or facilitators, what might underpin the success of our intervention. One of the easiest strategies to deploy to foster adoption and use of an evidence-based practice or an intervention is education. But education is something that you should use, that strategy is something you should use if the determinant is knowledge. If the determinant isn't really knowledge, it's people's motivations or their beliefs or barriers, kind of structural barriers to the way that they provide care, those types of education strategies may not be effective. So implementation science aims to understand what the determinant is and then deploy implementation strategies. And there are many taxonomies of implementation strategies. There are probably in one taxonomy more than 70 implementation strategies. There are some tools I'd be happy to share later that help you think about how to map determinants onto strategies. And there's a growing evidence base of strategies. So strategies like audit and feedback have been studied pretty extensively in the literature to show when and how they are effective. wanting to push down. Naykky, can you advance my slide? Thank you. You might have to, this has an animation. Go ahead and click all of them. Thank you so much. So this is an example of some implementation strategies from an Evidence Now project. And it's not all of the implementation strategies, but it's examples of ones that were successful in that project. The thing that I wanted to point out about it is that it does look, and I think Naykky said this earlier, it looks a bit like QI and like practice improvement in a lot of ways. You're trying to understand what's going on in the setting in which you're doing something. You might be using data to feed back to people to help them understand their practice, to look at changes as they deploy strategies and make improvements. But it also draws on the science of implementation strategies and in implementation, the entire evidence of the implementation science area. And so it's unique in that it has this really local feel to it. You have to go in and see what exactly is going on. We have all of these evidence-based interventions, but deploying them in different places might look really different. You might have to adapt your intervention. You might have to adapt the way that you implement it based on a really local type of situation. But by using these tools from implementation science, we're adding to this larger corpus of knowledge about how we implement these evidence-based practices in different settings. Other than that, oops, sorry. In the green box, the other thing that I like about the way that they're thinking about implementation strategies here is that there's this, to develop and distribute educational materials as a common strategy. But they also highlight capturing and sharing local knowledge and learning collaboratives. It has a nice flavor of how local groups think about their own implementation processes and share their experiences. Go ahead, Naykky. So let's jump to a case study so we can talk about this a little bit more. I've put a case up here. But you can use any case you want. So in this case, the evidence-based practice is around colorectal cancer screening. So we have a lot of folks in the US, this number is, who are not up to date on colorectal cancer screening. And there are significant disparities by race, ethnicity, rural residence, income, and education. Colorectal cancer screening would be one of those where there's lots of multi-level barriers. We're focusing here on barriers that are related to the clinician in the healthcare setting. And those barriers include failures of clinicians to recommend colorectal cancer screening, lack of identification of who needs it in the EHR, and belief that colonoscopy is the only screening tool. And your team has identified an evidence-based program. There are repositories of evidence-based programs or programs that have been tested in different settings. This is kind of a hypothesized one that draws from a few of them. Your team has identified an evidence-based program to improve clinician screening recommendations, that being one of the biggest problems. It includes EHR reminders and clinician education on screening options. So you have this evidence-based program, and now you want to bring it into your context. You want to hit the next one, Naykky? Thanks. So the way I'd like you to think about it, and I think now that I look at it, 1 and 2 are maybe a little bit transposed, but I want you to think about the potential determinants that you would investigate. You're bringing this program into your setting. What would you want to know about the people who are going to be using it or impacted by it, about the setting where it's going to be implemented, or the policy or external environment that the people operate in, their views on the innovation, and how would you know that, about those determinants? How would you investigate those? Would you survey people? Would you observe the practice? Who would you want to talk to understand the implementation context? If you have time, you can come up with some hypothetical determinants and strategies. Maybe a determinant around the type of setting and the type of strategy you might use to help deploy an intervention like this into it. The intervention itself is kind of hypothetical. It's an evidence-based program, but if you'd rather have your small group discussion and talk about implementing ICANN or implementing something that we've talked about in this conference, that is absolutely okay as well. So in the interest of time, rather than having everybody report out, we thought we would look for volunteers, maybe someone online and someone in the room, just to tell us generally how you approach this task of thinking about your intervention and how you would understand what was important in terms of implementation. Maybe I'll start in the in-person room. Is there anyone willing to talk a little bit about how you approach this task? Thanks, Sandra.
So we discussed the colorectal cancer screening. And so things that came up are the cost of the intervention, the access to healthcare services, how easy or complicated it is for a person to get there. And also a very important topic is making sure that patients know what the procedure means, how they have to prepare for it. And all of these are in a way barriers to getting people to go. And we were starting to discuss why people don't, like, what do you do to make sure that people show up? That's the first problem. And we didn't get further than just asking the question, but I think once you find a way of getting people just to be there, then the other things, that's a huge problem. And the colorectal cancer screening is so invasive, that's tricky.
Was there an online group that wanted to unmute and talk about their approach?
I can talk. So this is, the way we approach this is I kind of reflected on my own personal experience doing some of this work in a different context. And, it's really important to really understand what the problem is, because you can come in with preconceptions of, oh, this is the problem. But going in with observations and watching the encounters and saying, well, what is talked about? How is it talked about? Is it talked about? And, understanding that environment and doing interviews to get a better understanding of how do patients feel about it? How do clinicians feel about it? Maybe administrators are important stakeholders in the decision, doing that as well. And then you can even follow up with surveys to understand, well, is this an artifact of the clinic I studied, or is it system-wide type of issue? And that'll help you understand what are those factors that are impacting the implementation of this evidence-based practice. And then you can tailor your intervention to those particular barriers that are impacting the implementation of the evidence-based practice. And it's really important to look at how sustainable whatever it is you do is going to be, because unless it's integrated into their practice, unless they normalize it, you can see it work during that implementation pilot, whatever it is you're implementing, but as soon as you leave, you might see that whatever it is, the colorectal cancer, in this case, the screening start to go down again because it doesn't have that support, or they don't feel like they're being studied. And, I mentioned the term planned obsolescence. You could also talk about normalization of it into practice. But I think sustainability is probably one of the things that you want to look for with these implementation interventions.
All right. Do we have any other comments or questions about the implementation? I want to leave equal time for the de-implementation work that Naykky's going to talk about.
Yeah, I do have one question. We were talking in our group. Can you hear me?
Yeah.
Yeah, and in this phase of understanding the why something is not implemented, or what the barriers are, we thought that it was interesting that they never really actually look at the encounter itself. As it's a lot of focus on surveys, a lot of focus on qualitative work, readiness of the organization, but they really look at the encounter, and they assess what happens in that conversation as a way to understand why something is not implemented. Because implementing is usually seen in an uptake, adoption, but it's not seen as the fact that you're just having a conversation. So just maybe having the conversation is when we want to implement. But what are your thoughts about it? When should we look at this encounter as a way to understand why something might not be used?
I think, in my view, we think of looking at the encounters or doing observations to understand how things are happening in practice and thinking about the ways to optimize the evidence-based practice that we're doing. So in your scenario, is the evidence-based practice having the conversation?
So yeah, because one can think, and trying to add the patient-centeredness and the care that fits principles to this, one can think that in order to adopt or to increase the uptake, you can just do a variety of things that are not patient-centered.
Right.
You can pay people for it, but it doesn't mean that it's good for them. So sometimes what we want in order to promote care that fits is actually having meaningful conversations about that particular option in a way that makes sense. And so to what extent we are making it worse, just thinking about important outcomes that are not in the area of conversations or encounter science or encounter research.
Yeah. Was there a question that ended on that, JP? I'm sorry, I was following.
Well, yes, what I'm trying to ask is to what extent implementation bypasses the care that fits.
I don't know that it bypasses care that fits, but I do think that it is focused on the adoption of something that is good or that has evidence. And it can be a multi-level type of multi-component intervention that includes things that support clinicians and things that foster good conversations. I don't think that they're mutually exclusive.
No, yeah, and I agree. Yeah.
Sorry, I agree with that. And I think, as Jennifer presented, there was some of the barriers from the clinician perspective. But as she mentioned, you are looking at the problem like very systematically. So problems from kind of like patient access to the conversation, to what the clinician is bringing, to the where they are having that kind of like recommendation for getting the colorectal cancer screening and so on. But for the I think the discussion, she focused kind of like things that were maybe more clinician oriented. But I think my example might clarify some of that from the de-implementation angle, and also for time purposes, I think what I'm gonna show probably will clarify some of that, because I don't think they are exclusive. I do think that the language is not aligned, but the ultimate goals are things that I think everybody in the unit will be in agreement that, yeah, we want that to happen, because overall it seems that it's gonna be good for patients. All right, so let me, all right, so we'll do now kind of like the opposite part, which is kind of like de-implement something. And there's also like huge debate of whether it's just the opposite or whether it's something completely different that requires a different field of study. So this is a picture of my nephew. So he's 7. And again, just to try to make it a little bit more patient-centered, I'll kind of like center this around a hypothetical discussion with my sister in a time where there was no COVID. When I was talking to my nephew that I was going to use his picture for this presentation, he told me, oh, he was really excited. And he had 2 questions. He said, oh, I have 2 questions. So I got excited. I said, oh, he's going to ask me something about the work I do. But then actually his questions were, which picture are you using? And do I look cool? So I said that he looks cool, but if you disagree, let me know and I can let him know, although he might be a little disappointed. So let's, again, in a time before COVID, let's presume that, he started having some cough, feeling tired and not being as hyperactive as he normally is. So my sister will be concerned. He will take him to the pediatrician. They will do some tests and some assessment. And at the end, they will tell her, he has a viral upper respiratory infections. He's going to be fine in a couple of days, nothing that needs to be done. And then my sister, being my sister, she's going to call me and say, they didn't prescribe any antibiotics. And I was really hoping that they were going to give him some antibiotics, because what she wanted, or her concern, was that he wanted him to start feeling better faster and not just kind of having to wait. So this is kind of like really centered on a problem that I think many of us would like to work on. And trying to de-implement things that happen and shouldn't happen is not, as I said, something new or that people are working on isolation. You might have heard of this Choosing Wisely campaign in the US from the AVIM, but also across the world, there's like a international Choosing Wisely. The Journal of Hospital Medicine has Choosing Wisely with the label of things that we do for no reason. And then you might have seen all the data from Less is More from JAMA Internal Medicine. So for this particular example that I show you, the recommendations would be, again, based just on evidence, that antibiotics should not be used for viral respiratory infections. And this is because most of those, they are viral. So the antibiotics are actually not gonna improve anything. Again, there might be issues in the discussion because as I show you, my sister's concern was that she wanted him to feel better. So not necessarily these are kind of like in opposite of each other. It's just that the discussion might have not been the best. So the things I like about the implementation and the implementation is that it gives you kind of like a framework of how to think about problems and how to fix them in a very like systematic and well thought and logical way, as Jennifer described. So this particular framework for the implementation focuses first on kind of like the evidence, why we want to de-implement this practice. And sometimes it's because we have good data that this actually produced no benefit to anybody, or that first there was some data that it was beneficial, and now there's data that shows that it is not. So now the physicians need to kind of like stop doing something that they had kind of like good data on or believe in. Or you have kind of just controversial evidence, so it's not clear. Or you can have some things that are being done, but nobody has ever tested them, and they should have, compared to some other circumstances. We know that high quality evidence might not be necessary. So that's kind of like one way of thinking, or trying to identify a potential practice to de-implement. The other thing is, how bad is it? Like, why is this a problem? So one is the fact that this is happening in care. Is it harming patients? And then how many patients are being harmed? And whether as a result of the practice, we are kind of like worsening inequalities, or we are just, as I said before, kind of like wasting resources. And then on the other side, when you kind of like use this left side to identify practices that we do for no reason and that we shouldn't do, then you start thinking of fixing the problem with an action. So you can reduce, in this case, the use of antibiotics for viral infections, or you can replace it. So instead of prescribing antibiotics, something else, or you can completely remove it. So don't allow that to be prescribed, or you can restrict it. So it can be done until certain circumstances. And all these actions, to JP's point, you can design through conversations, right? And then as Jennifer kind of like showed us, then when you're thinking, okay, how do we get people to de-implement or do some of these actions? What are the barriers and facilitators at all these levels? So the patient, the clinician, their encounter, the setting, and the society, and what strategies we can apply to each of these actors. So that's kind of the summary. And as I said, I particularly like this because I think it's very well organized and systematic and well thought of. So this left side, as I said, it helps you kind of like identify and prioritize. So if you have something that there's really good evidence that it doesn't work, and on top of that, it affects a lot of people, and on top of that is not only that it doesn't work, but they cause harm, this is something that you want people to stop doing in practice. And then on this side, then it's more about planning, kind of like just not start doing things, but just planning and considering all the factors and understanding what is driving the problem, so that then the strategies that you have, as Jennifer mentioned, they match the problem. So it's just not saying we're going to educate if the problem is not lack of knowledge. And as I said, then this side of the equation will help you to facilitate that process and then to improve or de-implement that practice that is being harmful. So for this particular example, the strength of the evidence will say that routine of antibiotics for the management of viral infections is ineffective. Obviously, these are viral infections, so they are randomized control trials that there's no improvement, so patients are not going to be feeling faster as my sister wanted, right? And then there's also, it's a big problem. So 40% of children might be presenting with this kind of symptoms will receive antibiotics, and there are real harms. So it's not just that you get the prescription, but there can be GI side effects, for example. There are costs of medical care and medications. And then globally, there's all this other issue of antibiotic resistance. And then depending on the specific setting, this might exacerbate inequalities as disparities in care, or use resources that I think for most places are limited. So I kind of like did this part of the equation to say that this is an ineffective practice that affects a lot of people and that actually causes harm. So hopefully most people will agree that we should do something about it, that this should not be happening, or that we should to a certain extent de-implement this practice. And that will be what we want you guys to think of in the activity. Now, going to JP's point as well, in our way of thinking, you know, this patient-clinician interaction is one of the most powerful things that we have. But in this model, which was actually Aaron Lepine was one of the authors of this model, you are considering that this patient-clinician interaction is affected by the patient is coming in with their experience and preferences. The clinician is coming in with their attitudes and beliefs. This conversation is happening in a particular practice environment. And this practice environment is kind of like within our culture of healthcare and professional medicine, which might be more sometimes that more is better instead of the less is more. So with that, then the activity is going to be based on the example that I gave you, which was the antibiotics for children with viral infections. So if you were in charge of trying to, if I convince you that this should not be happening routinely, do you want to reduce it, replace it with something else, completely remove it or restrict it? And what barriers or facilitators can you find at each of these kind of like levels? What potential strategies? To very similar to the exercise that you guys did, although I think my example is a little bit more based on that kind of like patient situation. So Jennifer, if you want to break people into the rooms, and I think probably we can have people there 5 minutes or so and then bring them back.
I think all of the people are probably back from the breakout rooms.
The health system should allocate more time to provide good support to the healthcare professionals.
I agree.
I think one of
So,
For the society, I don't know what to do with the society.
so I think similar to what we did with the first activity, if either a group from the in-person and then one from online, kind of let us know how that process went, what thoughts they had, and how did that go?
How can you, even though you want to repeat it?
So I don't know if people heard me there, Jennifer. If you want
Hello
to,
in the room. Yeah. Do you want to start online or in person, Naykky?
I think in person and then online. Yes.
I don't know how well you can see who's raising their hand because everybody is jumping in.
No, I think you'll have to pick on somebody because I can't.
Is there anybody in particular who wanted to talk about their approach to this one? I heard lots of talk on this side of the room. I'm not sure about that side of the room. But...
I can share. Assuming that it has been stated that it's a viral respiratory infection, and I was saying that sometimes it's unclear, and then at that point restricting would be not be the correct way of moving forward. But if once it's stated that it's viral, we would restrict access to antibiotics. And in barriers and facilitators, we had just started discussing the setting, for example. This is a vary so much between countries. I was sharing one of the things I've learned in Mexico, and how when the prescriptions for antibiotics started, a subculture started. That's the pharmacy started to have a doctor just like next door, and people that wanted a prescription just went there, paid $1 more or less for the visit, and then they would give the prescription. And they had this like quota that they had to meet, and it's a mafia, like completely. And so if they give 10 prescriptions of whatever antibiotic, then they will get something in return. And what we were saying is you can't just restrict without what's going to happen afterwards. Like, what's the setting of your restriction? What are people going to do if there's no access to healthcare? Then what is the consequence of your restriction? And
Yeah.
further than that, but that's what we discussed.
Yeah, no, thank you. Thank you very much for sharing. And I think then, like, kind of indirectly, you're thinking, or with the example that you're bringing up, is that if you're restricted, you're identifying that both from the clinicians and the patients that there might be some barriers to that restriction, so that they will not accept that the prescription was not given. And I think as it was discussed yesterday, sometimes it just takes longer to explain why a medication is not going to be beneficial and should not be given than just going ahead and prescribing it. So I think with what you have highlighted, again, it just reinforces that this way of thinking can help solve some of the problems. And then I guess if somebody from the online group wants to kind of chime in and share how they approach this or what thoughts they had in terms of reducing, replacing, removing, restricting, and what barriers or facilitators to getting that done they think will come up.
So we reflected on how important is for this particular situation, understanding the patient and clinician interaction, and also the culture, as Sandra said, the culture of, for instance, Aldo reflected in the fact that in Peru, if you don't leave the encounter with a prescription for antibiotics, you're a bad doctor, and they just go find one that prescribes antibiotics. And that happens also in my country back in Ecuador. It's very typical. But perhaps, I'm not sure Ian brought this up, but we were faced with a significant challenge on patients with otitis media, children that were prescribed antibiotics when efficacy studies showed that it's not that efficacious. And when we watched those encounters, the problem that happened was that patients perceive this as an infection non-treated if you were not to give antibiotics. And when you switch that to ear pain or ear inflammation, then the clear outcome was why I should treat it with antibiotics and inflammation, which is at the end what the viruses do, is just cause inflammation. So highlighting what you put in there, that it would be very difficult to create the implementation project or implementation of project if you don't see the interaction, because a lot of nuances come from watching those interactions.
Yeah, and I agree, and that's why I think, although the language is not ideal, I think the implementation and way of solving problems completely fits or aligns with some of the work that we're doing. And as I was thinking of it, and I can imagine a conversation with my sister, if she were to tell me, well, they didn't prescribe any antibiotics, and I would be like, yeah, they shouldn't. And then her question would be, well, but I want him to be feeling better and faster, and I don't want him to have those symptoms. So then the conversation will shift into, well, what we can do for that to happen while he's waiting for the infection to pass, or things like that. So I also thought that there's definitely a space there for the conversation. And then with that in mind, just to kind of like move us forward here, for example, there's this, many people have thought about this problem and thought, okay, what if we use shared decision-making to then de-implement the use of antibiotics? So here, the barriers and facilitators, they were thinking that the patient-clinician interaction will be the best place to act. And then supporting shared decision-making there could help them reduce the prescription of antibiotics. So there's quite a few RCTs on that, and this is a review that looks specifically at this. And then the other thing that I thought is quite interesting was this idea of, instead of restricting or reducing, then replacing it. Because sometimes both clinicians and patients, if they are expecting that something is going to happen, they might not accept that it's not happening at all. So there's this concept in this particular case of, let's delay the antibiotic prescription. I think Sandra was also mentioning this. What if the diagnosis is wrong? What if the patient is, or the child in this situation, things are not moving in the right direction? So here, what they are saying is that don't in reflex write the prescription, but first give a few days with kind of like symptom management. And if that doesn't improve, then you'll give the prescription. And this comes from this idea of thinking with a kind of like the implementation hat of offering something, just not restricting or reducing, but replacing with something because it might be easier for people to do that if their beliefs or other expectations are too strong. So I think, Jennifer, you want to go through the summary, and I think we might have a few minutes in the end for additional discussions.
I think we have little to summarize formally. Our intent was to give some examples of what we mean by implementation and de-implementation science, how it's different from looking at interventions and thinking about patient outcomes, but thinking about how we encourage or discourage practices and behaviors in our healthcare settings. We did include at the end, if you want to just jump forward, Naykky, a list. People have provided great resources in the chat. These are some resources that we like for information about theories, models, and frameworks, including normalization process theory. You can find those listed here. And the D&I websites that we've included have a whole store of information about research design, strategies, outcomes, and evaluation. So a few ideas to get you started. Each of those would have various resources, including a couple that people have posted in the chat.